Hello, everyone. Welcome to the forum where we have outstanding speakers today to talk to us about long COVID. Just a little bit about Mask Together America. For those of you who are not familiar with Mask Together America, Mask Together America is a volunteer organization that was created by our wonderful creator, a wonderful founder there, Julie Lamb, who decided in the middle of the pandemic in 2020 to go out masked and photograph people, look at the impact that the pandemic was having on people, but how people were going about their business in 2020 when there were very little mitigations. The vaccine was not yet available. Looked at started taking different portraits of masked people. This is what gave her the idea for an advocacy for the layered mitigations, which you might have heard about. We often refer to it as the Swiss cheese layered mitigation, meaning that no layer in and of itself is perfect, but all together those layers will prevent infections. And those layers include, of course, masking, vaccination, testing, and of course, advocacy for ventilations, clean air, especially in public areas and non-ventilated and crowded areas. So Mask Together grew from this sort of portrait of humanity during a pandemic into this spearheaded by Julie into this volunteer organization, which now advocates for not just the layered approach to mitigation of respiratory sickness, but also to advocate for long COVID patients and advocate for finding solutions to long COVID, or at least raise awareness of long COVID and its effect on the population of patients at large. I don't know if you are patients among us, or or a scientist working, or a lay public, but there's been a lot of gaslighting of patients who have long COVID, unfortunately, by the medical professions, which is something that unfortunately always happen when there is a disease that's not very well understood, which shows into multiple different forms with multiple different symptoms. It goes all the way from being fatigued for years to CSF to even reawakening certain types of cancer cells. So, in between those gigantic batch of diseases, it's very difficult for the medical professional to pinpoint what to do. And when they don't know what to do, they tend to just not do anything, right? So Mask Together America has been very, very involved in the discussion on long COVID. Julie is part of the NIH Recover team and is advocating for patients there, continuously pushing for the recognitions of inclusion of patients, which is something that doesn't always happen. So she's been very good, very important in telling NIH Recover, 12 symptoms as a definer of long COVID is certainly not enough. Do better, right? There's much more than just 12 symptoms, right? Point of information, our dear host, Sarah, is in Minneapolis right now, so we want to send her all our good vibes for about what's going on. And unfortunately, part of what's going on, it actually relates to the lack of response to long COVID, and the whole debate about why should we mask to prevent respiratory illnesses. All of that is kind of connected. but we want to send you, Sarah, all our good vibes and hoping that you stay safe. And with that, I would like to invite Sarah to introduce our first speaker.
Thank you so much, Dr. Corthals, and I'll try not to cry. I appreciate that very much. Welcome, everyone. Thank you for being here. Our first speaker tonight comes all the way to us from Ireland. Her name is Sinead O'Brien. She founded Clean Air Advocacy Ireland with Dr. Sierra Steele and a collective of concerned individuals in Ireland in September 2024. This came about after a failed local election campaign where she attempted to highlight the ongoing issue and dangers of the unmitigated spread of SARS-CoV-2 and how indoor air quality can affect the spread of harmful airborne pathogens. CAAI continues to highlight these issues and is keen to offer solutions to reduce the spread of SARS-CoV-2 and other airborne pathogens for improved community health. So welcome, Sinead. We're so happy to have you. Our
Thank you for
first
having me.
question, yeah,
Sorry.
our first question tonight is, what is long COVID to you?
Hmm. Um, well, I think Dr. Corthals kind of touched on it a little bit there in her introduction. Because without going into, all the symptoms, I'll leave that to the experts who are following me. Um, Really, I think it's the most underestimated risk currently in our globalized society it's just being completely ignored. And I think it's honestly, I could be accused of over egging it or exaggerating the situation by saying it's the biggest risk, but really I do believe that, not just because of the symptoms and the kind of the long-term disease that it is causing in people and continues to cause as COVID is pervasive. It's also in how we've completely we're losing our humanity in terms of how we're dealing with it, by ignoring people who are affected, by you know not providing mitigations to prevent the further infection of people who are vulnerable or not vulnerable. It's we know what it's doing to our bodies and to people, and I just think it is a global threat at this point that it's continuing to spread without anything being done about it.
Hear, hear. In your opinion, what is the key to preventing long COVID?
I think avoiding COVID is the ultimate key to preventing it. But as someone who I've had COVID twice now. I'm really extremely grateful to the scientists and researchers and public health communicators who have put information out there that I was able to read to help me avoid the long-term consequences. And I may have just been very lucky, but I understand that, if you do get COVID, resting is pretty key. And that's what I did. I took that on board and just radically rested, as they say. So I informed my husband I'm not doing anything for a while. So that has helped me, I think. But again, I could just be very lucky.
Why do you think people are reluctant to invest in clean indoor air, like air purifiers and ventilation in public spaces? Are they concerned that it's too expensive, or is there something else?
I think it's there are multiple factors. One is that I'm talking from the Irish context. I don't know exactly. I can't speak for America, but in Ireland, I think once the vaccines came through and we had a really high uptake in Ireland when they were first issued. And I think people then just decided, okay, well, that's it. We're vaccinated. We don't have to think about the pandemic anymore. We don't have to think about COVID. We're protected. And so mentioning even ventilation or mentioning HEPA filters, I think it's triggering to people. They think that, oh, this is COVID. And they just have this mental block in discussing it. Um, for those that are kind of open to the discussion, cost is a factor. So I know we have a lot of members in our group who have school-age children, and they themselves may be immunocompromised or have immunocompromised children, and they've approached their schools to say, can we bring in HEPA filters into the classrooms? And one of the issues is costs. They're like, oh, well, if we do it in one classroom, then we have to do it in all the classrooms, and that's going to be too expensive. And then another issue that gets raised by teachers is the noise. They're saying, oh, well, the HEPA filters are too noisy and it's too tiring for our voices to speak over it. And like, I don't know what initial HEPA filters were introduced in the early days of the pandemic, but certainly it seems clear that there are HEPA filters on the market that are not that noisy. So that I think it really needs to be revisited. But so it's a long-winded answer to your question, but I think it's multiple factors. There's kind of a mental block, anything that reminds people of COVID and the lockdowns and the early stages of the pandemic. They don't really want to hear about it. So that's why one of our approaches is to kind of just take a broader look at air quality and also look at other pollutants that might be in the environment and kind of approach the conversation from that direction, from a more environmental aspect, as well as like high CO2. That's not a great environment for learning in or for working in, and so making efforts to kind of promote the reduction of CO2 in our indoor environments is another angle that we've chosen to take to kind of promote clean indoor air.
How do you deal with journalists who play down long COVID and stigmatize masking and cleaning the air?
That is a problem I wish we actually had more in some ways, because like honestly the big hurdle we have is, in sending out press releases or trying to get this conversation going in the media, is it just hits a brick wall. I think it's very hard to get this conversation going. Just again, for those reasons that I mentioned earlier, like people just have this mental block about the pandemic and COVID. Um, One of the things that we found useful in just getting anything published is to really stick to the facts, like just and we have a great member in our team who it works in PR and communications and is a very good editor in just hacking away and keeping the message very focused. Um, and gosh, what else? Latching on to, I suppose, arguments that are made by somebody else. So let's say there's an academic who's published something in the paper, we can kind of build on that argument and point, well, actually, if we clean the indoor air, we wouldn't have, this crazy amount of school absence that we're seeing now in Irish classrooms. So that was one angle that we took. But then, like, we did try to warn the public through the media about the flu, like the record-breaking flu that was hitting us all over the world. And that was a real struggle because we were up against our own public health body, the HSE, the Health Service Executive, who put out their own press releases. And of course, the media is going to take the official statement from our, National Health Service Executive over a small little group like ours. That is the challenge.
Millions of children have long COVID. What can parents and schools do to protect children?
We all know the answer to this. It's stopping the spread of the illness in the classroom. So we want clean indoor air. What we really want is better, I suppose, policy around attending school while sick. I mean, we had in Ireland a very good, well, as good as you could hope for, policy where the health service executive advised parents not to send symptomatic children to school, but that was dropped in 2025 because school attendance numbers were down by a very dramatic amount. And so they started saying, like, send your kids to school even if they're symptomatic. So that is hugely problematic, because it's just going to exacerbate the problem. Because if you're sending symptomatic kids into school, it's just a vicious cycle at that point. So yeah, for parents, and did you say schools or teachers? Sorry, I can't remember the question. But for the community to, prevent the spread of airborne illness and COVID. Clean indoor air, encouraging masks. It's a very touchy subject over here. I don't like, I know on some of the posts with Mask Together America, people have commented that they've been to Ireland and nobody masks here. And I don't know if that's low population numbers, you're not seeing those that mask, but it is true. Like there's a very low number of people that you would see masking by walking around here. So yeah, like it's something that I do with my toddler and she's taken to it very well, but I mean, it's going to be a tough one to encourage other parents to do that.
I also think if they were criticizing Ireland about that specifically from the US, that might have been a little bit hypocritical, but we're always trying to get more people to mask here too.
Yeah, but Ireland, we're just very behind. Like, if you think America's bad, I was in California over Christmas, and I was amazed by how many people were masking compared to here. It was dramatically more.
Well, I'm glad you had that experience.
Mhm.
Send some of them to Minnesota. What do you think government should be doing to protect adults and children from long COVID?
Information. That's one thing that I think, if people were actually informed of the risks, I think everyone would be taking a little bit more caution and trying to avoid COVID infection. That's certainly what motivates me, knowing the potential risk in getting infected, is what keeps me masking and, cleaning the air and testing and doing all the things to help mitigate getting COVID. So yeah, well, I mean, ideally, our public health bodies would actually put this information out there. But failing that, I suppose we're kind of on our own and working together to build that awareness out in the public. So that's kind of what we're trying to do with Clean Air Advocacy Ireland, and giving people, I suppose, creating awareness of the tools that exist to help reduce the spread. So that's again just cleaning the air, ventilating. If you can't, if you know you don't, in Ireland we have a lot of older buildings that don't have proper like ventilation systems in place, so it's kind of just opening windows and introducing HEPA filters. Yeah, those are kind of the fundamentals.
Are there any wins or positive steps for clean indoor air that you see the government taking in Ireland or anywhere else in Europe?
Yeah, well, I think it's a partial win in Ireland, in that we do have a code of practice on indoor air quality, and that's published by the Health and Safety Authority, and that is now given legislative backing in the Workplace Safety Acts. So there is legislation in place that requires employers to provide healthy indoor air for their workers. The issue that we have is that while that code of practice exists and it's backed up by legislation, it's in law, um, it seems to be very difficult to enforce and to actually, put put it into effect as an employee. So I've been looking through the case files last year. I haven't done it recently, but last year I couldn't find anyone that actually took anything up against their employer on the basis of the air, getting infected or coming down with any illness due to poor indoor air quality. So it's something that we'll keep an eye on. But what is promising as well, kind of from the European Union perspective, is that there is legislation coming into place. It is called, I wrote it down actually just to remember. It's the Energy Performance of Buildings Directive. So that is a directive that will be coming into effect in 2007 or 2027. And I think all member states have to transpose that into their national laws this year. And that does require, I suppose, plans to improve the indoor air quality in all buildings, not just new buildings, but in kind of renovating and retrofitting buildings to be more energy efficient. They have to also look at the indoor air quality aspect as well. So that is it's promising. It's just everything is so slow. You know, we'd like things to happen now, but to see these things on the horizon like that is encouraging. And what's also encouraging is looking at the kind of number of EU funded research projects that are focusing on air quality. Now, my colleague, Dr. Ciara Steele, who I think is here as well, she's currently working on a project up in Donegal that is focused on air quality, and she's managed to get a portion to look at the indoor air quality aspect. So that's a major win by Ciara because originally the project was really just focused on the outdoor air quality aspect. But, you know, outdoor air gets inside. It's something that we need to look at as well. So that's kind of been the approach that we have found small wins in, is to look at the indoor air quality aspect from an environmental side, because that's where the funding seems to be going and where the legislative interest is. You know, at the moment it seems like nobody really wants to talk about COVID or long COVID when it comes to the air.
Some parents think there's no benefit to their child being the only one masking, so they choose not to have them masked at all. How can we convince parents that one-way masking is still better than not masking at all?
That's a really tough one. I can understand the logic, because, you know, especially if you're sending your kid to school and there's not a lot of masking there, it sort of feels like an inevitability that everyone's just going to get sick. And that's the mentality that I come across here all the time. You know, people say like, well, once your kid's in school, they're just going to be on a conveyor belt of sickness. And I just think that I mean, it's unfair on the child, it's unfair on the parents to be constantly minding sick children and getting infected themselves. I personally, I one-way mask out in the world. My daughter, who's 2.5, masks one way when she's out in the shops or wherever, on airplanes and in airports. And for me, like the motivation is just avoiding being sick, whether it's COVID or a cold. Like, it's just really inconvenient to be sick, especially when you're minding a child. You know, it's pretty exhausting to be caring for another being, but like with them being sick is just so much more challenging. So that's what I suppose motivates me, but it's hard to know how to motivate other parents, because I just don't understand how people can be so tolerant of the constant infections that we're seeing. I think it'll come down to just eventually it be normalized. Like, that's why I do on occasion share pictures of my daughter wearing a mask on social media, just so that people can see like it's possible. You know, it's not impossible for a 2.5-year-old or 2-year-old to be wearing a mask. And similarly, like going to her doctor's appointments or you know, vaccination appointments, when a nurse sees a 2-year-old wearing a mask, you can see they're kind of processing like, oh my gosh, like a 2-year-old can do it, why can't I? You know. So yeah, I think it's going to take time for this to be normalized. I have no easy answer there.
Yeah, truly, your 2-year-old is doing the work more than many adults. So good for setting a good example for everyone that you encounter.
Mm.
What are the challenges a grassroots organization faces in advocating for mitigation?
Sorry, can you repeat that question again?
What are the challenges a grassroots
Oh,
organization faces in advocating for mitigation?
I think for us, as a group, it's that we're fairly new on the scene. So it's kind of establishing ourselves as a reliable source, especially when we're sort of, I don't want to say talking against the public health authority in Ireland, but you know, we're advocating for clean indoor air, we're advocating for masks in healthcare, you know, we're advocating for things that um, our public health authority isn't really talking about. So yeah, I suppose gaining trust with the public who you're trying to inform. That's a key, that's a big challenge. And then just being able to actually get your message out into the world. That's a big challenge because I mean, that's ultimately who we're trying to get through to. And when the media is not really on our side, that's yeah, it's a big struggle. So it's something that we're kind of looking at this year, getting more out into the public domain, to just get talking to people. And I think that's how we'll build ultimately, because yeah, the media, it's a slow moving beast when it comes to adopting the message that we're promoting.
Thank you so much. Those are all of the questions that we had for you, and you still have about 5 minutes left. If there's anything that you'd like to promote, or, I like to offer people the opportunity kind of to talk about anything that we maybe didn't address in the questions.
If you're interested in what we're talking about or want to engage with us, our website is Clean Air Advocacy Ireland, and we're on various social media channels, so Instagram, Facebook, Blue Sky. I think we're taking a break from X with all the scandal surrounding that. So please feel free to reach out to us, and we'd love to collaborate wherever we can. And thank you very much for your time and for inviting us onto this panel.
Thank you for being here. I know that it's a little bit later where you are than it is for most of us. So thank you for taking time out of your evening to be here. And yes, folks, check the chat. It's Instagram.com/cleanairie, and the link is in the chat. So if you'd like to follow Clean Air Ireland on Instagram, that would be wonderful. Our next speaker is going to be at 5:45 Eastern.
Thank you, Sinead. That was great.
Thank you, Sinead. That was fantastic.
Yes.
I hope that was okay. Are we on still in public domain, or
We are.
We
we
are.
are?
Yes.
Chatting
All of
while
these
people can take a break.
Yeah.
Okay.
Yeah.
Well, thank you. That was, I hope I answered the questions. I may have gone off on a tangent on some of them, but they were good questions. I enjoyed them.
Yeah, the one about the children is really problematic. I mean, we're surrounded with parents who want to do the right thing, but the school doesn't provide any, context in which they can do this. And then there's also the bullying, right?
Yeah.
You send your kid to school with a mask, they're the only one masked, they get bullied.
Yeah. So that's something that I haven't had to deal with yet, but it's definitely a challenge. Um, yeah, I don't like, I think the kids who continue to mask have really thick skin that'll stand to them
Yeah.
for years to come. But it's tough as a parent to just, know that the challenges they face in schools.
Yeah. And I have a friend of mine who's been masking until very, very, very recently, but once her kid started going to school, she got COVID 3 times with it. Like, she had not gotten COVID, and then in 2025, her kid started going to school and she got COVID literally three times within the same year
Wow.
from the kid coming back, which is impressive considering that, it takes a while generally between infections.
Yeah. And that is surprising that I mean, I presume she would have been vaccinated as well,
Yes,
to have with,
absolutely.
so,
Vaccinated, boosted. It was just
yeah,
really surprising how often she managed, or 3 times in a year. It's
in a year. But that is just
almost
unsustainable.
yes, it's almost a record. Yeah.
Yeah. But
It's like,
I mean, that's the concern, is like, how many times can we all get COVID in a year, over the years, sustainably? It
yeah.
just doesn't seem.
And then there's, the question of, sometimes you might not even notice that you have COVID because, while the vaccine is useless in terms of transmission. I mean, not
Hmm.
completely useless. It does help with a little bit with the transmission, but not much. Um, it does lower the symptoms that you might have. Some people may not even notice that they have any symptoms, and they don't realize that they've had COVID until they get to the point where they might develop long COVID, right? And so it's that's another added layer to the long COVID problem, because you're going to go to the doctors and say, hey, I'm feeling fatigued. I have these nervous problems. Or I have this, that, and the other. My arthritis, for some reason, has risen up. I have this runaway inflammation.
Hmm.
Um, and the first thing they will ask is, well, have you had an infection, right? And it was there, but it was
But
silent.
they missed it. Yeah,
Yeah.
I know. That's my concern. Like that's why I do test randomly, just to be sure in case I want to go for a run or do some exercise.
That's
That's
yeah, that's smart.
it. Well, it's just another. I should have mentioned that earlier, but it's just another way of avoiding long COVID is just spot check.
Yeah, exactly. And tests, I don't know if this what the situation is in Ireland, but tests are getting harder and harder to find in pharmacies.
Wow. Okay, because here they're still available, but we actually use the oh my God, I can't remember the PCR one.
Oh, not Lucira. Yeah, there's several ones, but hang on. I think I have it here as a matter of fact.
I'm blanking. It's in the other room. We usually have it here.
Yeah. All right, let me see. Did this one that you're using?
No,
Aptitude? Nope.
no, it's not. Oh my God. I might just give me 2 seconds.
Yeah.
It's the Plus Life.
Yes, the plus life.
That,
Yes, yes, yes. Yep.
sorry, I don't know why that's not focusing at all. Um,
Yeah, and
yeah, that one just seems to be, I'm told, reliable, so that's what we work with.
somebody mentioned in the comments that metrics is expensive, so is plus life. Each separate test is not cheap.
No, no, they're not. So as a family, we do pooling, like so multiple tests in one. But yeah, especially after travel or riskier scenarios, it's just nice to know that you're in the clear.
Yeah, yeah, absolutely. No, it is pretty reliable. I actually tested it in my own lab and against
Hey,
an actual PCR, and it was quite reliable.
it's good to know.
Yeah.
Yeah.
Metrics too, but I think Metrics is slightly more expensive than Plus Life.
Okay. Yeah. I don't know about getting things in the US these days. Everything's probably more expensive with tariffs and all. So that's another challenge.
Another layer, yeah. And
Yeah.
so, when I was mentioning the similarity, like the sort of thread that runs between the pandemic all the way to what's going on in Minneapolis, it's also a question of, community
Hmm.
this sort of erosion of community bonds that has been going on. Like, the lack of masking is also not caring about community, right?
Hmm.
The anti-vax movement, boy, has that been co-opted, right? So yeah.
Actually, since you mentioned the anti-vax, that's another angle that I've been thinking would be good to encourage parents to get their kids to mask again because, if there's measles going around now, if there's all these other archaic, pathogens spreading,
Hmm.
like
Yeah,
you gotta
polio.
use what you yeah, oh my
Polio
God,
is like, yeah, yeah,
crazy.
it is. It's nuts.
But that's unfortunately like the anti-vax movement or whatever you want to call it that is sort of gaining traction here because I was just looking up the vaccination uptake in Ireland for the flu and COVID vaccine. And for healthcare workers in Ireland, let me go back to the actual stats, but it was something like 8% took the flu vaccine. Like
Oh,
health workers in Ireland, 8%.
that's nothing. No, this
So
is
we're just going backwards.
yeah, yeah. No, absolutely. Yeah, we have that problem as well here.
Sorry,
Uh,
sorry, sorry. What? No, maybe it was actually better than that. Sorry, I'm mixing up stats. But that was for influenza vaccine uptake, it was 33% HSE only healthcare workers. So that's something.
yeah, that is
Oh,
something.
but
Does that, yeah,
it was the COVID vaccine that was 8%, 8.6%. So
yeah, yeah. We've things have not improved here. I mean, it's quite remarkable that how this movement has been co-opted in the political sort of shift that we're seeing around the world, right? So, um,
yeah, but it like that political shift, I think, and I think a lot of people here probably agree that it really took off with the, I suppose, mitigations around COVID. So, I
yeah,
mean, over
oh,
here,
absolutely.
it was that anti-vax thing, it was anti-lockdown. It was like, complaining about government overstep, overreach, like we want our freedoms, blah, blah, blah. But what's confusing and disappointing is how so many people who are otherwise very reasonable
Hmm. Hmm.
have just followed that illogic, like they're
Yeah,
because it I guess it's preferable, or because it's inconvenient to mask, or it's not comfortable,
yeah,
or it's inconvenient to take precautions around COVID and whatever, but it's playing into the hands of fascists at this point. It's
yeah,
promoting
absolutely.
ableism. It's just I don't I don't know how to get through to people who are otherwise totally reasonable, but just yeah, have a big wall up against this topic.
Hmm. No,
Sorry,
absolutely.
I'll mute myself because I know there's more speakers.
No, we've still got 5 minutes. You can keep talking.
And where are you, Dr. Corthals?
Yeah, in New York,
In New York. Okay.
like
So
Julie.
you had a pretty bad flu season there as well.
Yeah, but actually, I have to say, the New York City Department of Health is incredibly good compared to the rest of the country. They're very good. They've been very good at putting out mitigation messages out there for masking, and under the push from people like Julie and Mask Together America, they actually have pushed the idea that you shouldn't wear a surgical mask, but actually a well-fitted mask.
Hmm.
At the very least, KN95, and even better, an N95. So I have been well impressed with their work in messaging. It sometimes appears a little late, but better
Mm,
late than never. Uh,
absolutely. I noticed that. And the Durham County, is that in North Carolina?
oh
Their
yeah.
public, they've been very good as well. But again, you just wish it was out a little bit sooner. And maybe it was, but we're only just seeing it a bit late. I don't know.
Yeah, like not reactive, but proactive. So yeah.
Yeah.
Hmm.
But we're not even reacting over here. We're just like we that like
Yeah.
the one of the HSE figures came out saying, "Oh, we're anticipating a rise as kids go back to school, effectively."
And that's
So
it.
they
Yeah.
anticipate it, but do nothing to stop it or to try and reduce the damage.
Yeah. Yeah. So I think it was the Department of Health in California that had a campaign before the holidays. Like I think around Thanksgiving, they said, "Look, you're gonna go on holidays. We're gonna, we know you're gonna be in airports and airplanes.
I
Try
think
to
Dr.
mask."
Akiko Iwasaki is ready. She said that I have a hard stop at 6:15. So maybe we can start.
Yeah, we can start a couple minutes early. That's completely fine. Let me just pull up my notes.
Hi, everyone.
Hi, Dr. Iwasaki. Thank you for
Hello.
being here.
Thank you for having me.
All right, our next speaker is Dr. Akiko Iwasaki. She's a Sterling Professor of Immunobiology at the Yale University School of Medicine. Her research focuses on the mechanisms of immune defense against viruses at mucosal surfaces, which are a major site of entry for infectious agents. Professor Iwasaki received her Ph.D. in immunology from the University of Toronto and completed her postdoctoral training with the National Institutes of Health before joining Yale's faculty in 2000. She's been a Howard Hughes Medical Institute investigator since 2014. Professor Iwasaki has received many awards and honors, including the Keough Medical Science Prize in 2025, Forbes 50 Over 50 Innovation 2024, Time 100 Most Influential People 2024, Time 100 Health Most Influential People Affecting Global Health 2024, and the Elsie Kroner Fresenius Prize for Medical Research 2023. She was elected to the National Academy of Sciences in 2018, to the National Academy of Medicine in 2019, to the American Academy of Arts and Sciences in 2021, and was appointed President of American Associations of Immunologists in 2023. Professor Iwasaki has been a leading scientific voice during the COVID-19 pandemic and is also well known for her Twitter advocacy on women and underrepresented minorities in the science and medicine fields. She was named to the 2023 status list of the ultimate list of leaders in life sciences. Professor Iwasaki is the director of the Center for Infection and Immunity and is at the forefront of several long COVID investigations, including the Mount Sinai Yale Long COVID Study, Yale Listen Study, and the Yale Paxlovid trial. So thank you very much for being here. That is a very impressive list of accomplishments, and we are very honored to have you here.
Thank you so much, Sarah.
Our first question tonight is for research. What should a long COVID definition look like to reflect diverse patients, varying long COVID etiologies?
Yeah, so this is a question that a lot of us are asking all the time. So if you look at the National Academy of Science, Engineering, and Medicine definition, it is intended to be highly inclusive, which is very important to capture all spectrum of disease. So it's really literally a chronic condition that occurs after SARS-CoV-2 infection that is present for at least 3 months. And so, this is a very broad definition. And so I'm a basic scientist and we do immunological studies. And we rely on our clinical partners to make the long COVID diagnosis based on their experience and their, basically data that they've accumulated over the last 5 years. And so I'm very fortunate to collaborate with people like Dr. David Petrino, Dr. Lisa Sanders at Yale, and Dr. Michael Peluso at UCSF, who are all dedicated clinicians who see patients with long COVID. And their diagnosis of long COVID status is what enable us to study people with long COVID. And if you look at the symptoms and severity, they vary among the different patients, but typically they include things like persistent fatigue and post-exertional malaise, brain fog, sleep disturbances, plus this 200 other symptoms that's been reported. But these core symptoms are really, I think, important. What unites these people together. Now, you asked me about long COVID etiologies. We currently don't have a clear sense of what is driving long COVID in each patient yet. We're pursuing different hypotheses about the root causes, but clearly we cannot draw a causal line between persistent virus and these symptoms or autoimmunity and these symptoms. So we're still a little bit far away from symptoms diagnosis based on etiologies, but we've come a long way actually, in the last 5 years.
That's great to hear. What do you think about a symptom-based research definition being used to diagnose patients for studies?
Okay, I think you were referring to the Recover Long COVID Research Index that's being used in the Recover studies. So I think every study has different research-based definitions for enrolling patients into various studies, but I understand that the Recover Long COVID Research Index is based on point systems that puts, for example, 7 points for loss of smell and taste, 6 points for post-exertional malaise, and 1 point for fatigue. And because the Omicron variant pathologies really don't involve a lot of the loss of sense of smell and taste as much as it did in the original virus, the kind of weighing the loss of smell and taste 7 points may actually not capture patients who develop long COVID after the Omicron era. So, this may need to be revisited, but, each place has its own definition for enrolling patients. We are currently doing sort of all comers for different studies, but in the future, it might make more sense to focus on patients with POTS or patients with sleep disturbances to learn more about the unique immunological signatures for these groups.
Does long COVID worsen in severity over time? And is it important to study patients at their early stages?
Absolutely. I think long COVID, it's just like other post-acute infection syndromes, that the clinical and biological features tend to shift over time. And so it's very important that we do longitudinal studies of patients with long COVID in the earlier, even if we can capture them before they get exposed, we can really learn about the changes that occur in the immune signatures as well as clinical symptoms. And there was a recent study by the NIH Recover team that found 8 different disease trajectories in long COVID patients. And so, it's very difficult to say a priori what kind of trajectory a patient might follow. But unfortunately, only 9% of the patients recovered during this observational time. So it's really a dire situation. We really need to, study this further. And I just feel like the effort that the government or the funding agencies are putting in this disease, it just does not match the criticality and the severity and the dire sort of urgency of what we need to do now.
Are patients being left out of medical trials who have comorbidities, such as autoimmune disorders exacerbated or triggered by COVID?
Yes, you're right. Many of the clinical trials require certain sets of conditions to be met, and that means that some patients with autoimmune disorders may be excluded from such trials. And I think the reason for this is because long COVID is already a heterogeneous disease, the clinical trials have to really be designed to see positive signals that really target the root causes of long COVID. So by including patients with pre-existing conditions, it makes it a little bit difficult to understand whether a drug is impacting the long COVID feature or maybe treating the pre-existing comorbid conditions. And that's why many studies, including our own, have excluded patients with pre-existing conditions. However, in reality, many who develop long COVID have had comorbidities like autoimmunity, and having these pre-existing conditions, including autoimmunity, allergy, and inflammatory diseases, is a significant risk factor for developing long COVID. So I really think that in the future, we need to design studies that take into account patients with these pre-existing conditions and, the drugs that are identified in people without comorbidities can be then rapidly tested in long COVID patients with these diseases. And because in the end, it doesn't matter whether the drug is treating the pre-existing autoimmunity to make people recover from long COVID. It really doesn't matter what the actual sort of targeting is, as long as the patients recover. So I do feel that we need to, in the future, expand the cohort to include people with autoimmune diseases.
What types of medicine should be repurposed and tested for treating long COVID?
Yeah, so before I answer the question, I'd like to just sort of recap some of the root cause hypotheses that we have been working on, because it's important to think about repurposing of drugs that target these kinds of pathologies and root causes. So, there's this idea of persistent SARS-CoV-2 infection that's happening in a subset of patients. And there's also autoimmunity that can be caused by the acute infection that then lingers. There is also herpes virus reactivation. We and others have seen that, EBV, VZV, herpes viruses. There's also chronic inflammation that is triggered by the acute infection that just isn't repaired. For instance, with Michelle Monge's team, we showed that even an acute respiratory restricted SARS-CoV-2 infection in animal models causes persistent brain changes that can really explain brain fog and memory issues and other cognitive deficits. So it could be like this sort of unresolved chronic inflammation. And also there's many other hypotheses like microbiome dysbiosis, clotting issues, dysfunction of mitochondria. So based on these insights, we need to be testing patients who have signatures of these root causes with targeted strategies. For instance, for persistent virus, we could really test, potent antiviral medicines. We did test Paxlovid, and so have other groups, and that 15-day of oral Paxlovid was not enough to make a difference, unfortunately, in the symptoms. But there are things like potent monoclonal antibodies that are out there that can be tried to see if we can get rid of that persistent virus and get rid of these symptoms. There's also, in the autoimmune space, there's a lot we can do. For instance, the B-cell depletion therapies or FcRn inhibitors that reduces the level of autoantibodies. This should really be tried in patients with long COVID. There's also the chronic inflammation that's targeted by JAK inhibitor, baricitinib, which is a large clinical trial that's led by Dr. Wes Ely at Vanderbilt. So I think that we are really trying to find the medicines that are already FDA approved for other indications to see if we can benefit patients with long COVID with an existing trigger that is matched to that drug. So I have hope that these trials will show us something. And also negative data are as equally important, because we don't want to be trying over and over a strategy that's not going to work, right? We need to target the most promising avenue for patients. So I think having had at least 2 or 3 randomized clinical trial with Paxlovid that has negative or just no effect, it's very important that we understand that. So doing more and more randomized clinical trials, even small pilot clinical trials, just to see if there's any signal, and then we move on to the next drug. I think that's very important to do a rapid cycling of these testing now.
How does COVID cause damage to the immune system and lead to long COVID?
Yeah, so this is the question that we've been tackling over the last 5 years. So COVID seems to impact the immune system in multiple ways. So we and others have found increases in exhausted T cells, and that seems to be happening because there's persistent viral antigen. And when the T cells can't clear that antigen, they keep being stimulated and become exhausted. There's also, we see evidence for skewing of T cells to type 2 immune signals, which is just kind of odd because for viruses, we really need type 1 immune response, but we're seeing type 2 immune cells in patients with long COVID. We also see defective antibody responses, increased autoantibodies, impaired myeloid functions, dendritic cell subsets, complement activation, vascular inflammation, platelet activation, dysfunctional hypothalamic pituitary organ axes, many others. So it's just, I feel like the long COVID is really impacting multiple aspects of the immune responses, and that is really kind of contributing to the disease, but also maybe explaining why some people develop long COVID when they are locked into this sort of maladaptive immune responses. It's also important to note that people who are immunodeficient are also at higher risk of developing long COVID. So the lack of ability to control the virus replication early after the infection really is linked to rapid dissemination of the virus and establishment of persistent replicating sites in the body. So, we see evidence from multiple studies that activated T cells as well as viral RNA and protein antigens are present in various organs from people with long COVID. And so these root cause hypotheses that I described are likely being initiated by the persistence of the SARS-CoV-2 virus that then leads to dysfunction of B cells that then stimulates autoantibody secretion and chronic inflammation and so on and so forth. So I think that, this really means that stopping the virus altogether, of course, it would be the best. But even if he got exposed, if we can clear the virus rapidly, I think we can prevent the onset of long COVID.
Why are long COVID patients at high risk for co-infections or reactivation of latent infections?
Yeah, so this kind of relates to my earlier answer about the immune dysfunction that we see in patients with long COVID. So once the immune system is altered in various manner in long COVID, the patients can no longer contain the latent viruses. And unfortunately, these latent infections like EBV and VZV and others have the sort of opportunity to reactivate in patients because their T cells and B cell responses may be impaired. And it's also possible it's the other way around, that the patients with this reactivation, are just unable to clear the SARS-CoV-2 virus very well because of the persistent reactivation that's happening. So we don't know which way it goes yet, but our most recent unpublished data is really showing that there is a link between herpes virus reactivation and fatigue, for instance. So I think to draw causal inference, we need to do sort of animal studies to be able to say that this caused this. But currently using clinical samples, we're already seeing a lot of link between reactivation of herpes viruses and the symptoms and the outcomes of disease.
Is SARS-CoV-2 oncogenic? Should long COVID patients get extra screenings for cancers?
So this virus is not widely recognized as an oncogenic virus. Oncogenic viruses we tend to think are things like human papillomavirus, that encode specific gene products that block tumor suppressor genes. So, for instance, the E6 of HPV degrades the P53, which causes death in cells with DNA damage. And so we don't really see that kind of direct blockade of tumor suppressor mechanisms in SARS-CoV-2. There are some reports suggesting that some of the viral proteins may indeed do these, but I think we need a lot more studies to confirm such findings. But I just also want to emphasize that a virus doesn't have to be oncogenic in order to promote cancer in patients. So, for instance, persistent infection can lead to chronic inflammation that then induces cancer. Example, hepatitis C virus. You can also find cancer rates increase in patients who have immunosuppression due to HIV, for instance. So any kind of immune suppression or immune deviation caused by a virus could ultimately lead to increased rates of cancer. Because the immune system is constantly surveying for transformed cells and trying to get rid of them. And when we interfere with that process in any way, the cancer rates may go up. And there was an interesting study last year that found increases in all cancer rates, death after COVID. And so it may be, again, there's a lot of confounding factors that could explain that, but it may be that SARS-CoV-2, without being a true oncogenic virus, still may be able to promote cancer in patients. So I think we need to have an open mind and investigate this further.
An estimated 400 million people worldwide have long COVID. Is it appropriate or excessive to routinely wear a close-fitting respirator in public places for protection? And what should people do to prevent long COVID?
Yeah, so the best way to avoid long COVID is to avoid the infection. So wearing properly fitted masks in public places, especially indoor settings, make total sense to me. I'm always wearing masks in crowded indoor settings and airplanes and trains, and just to avoid infection and exposure. It's not just COVID, right? There's flu and many other pathogens that are out there that you can inhale and become sick from. So I heard just the tail end of what was being discussed with Sinéad O'Brien, but I think that wearing masks makes sense to me. And additionally, staying up to date with vaccines can help reduce the risk of long COVID. So that's another thing that one can do to prevent, not prevent altogether, but to reduce the risk of developing long COVID.
How can a government take action against the rapidly growing worldwide prevalence of long COVID?
Oh, this alone can take an hour. But there's a lot that the government can do to help deal with rapidly growing incidence of long COVID. For example, the obvious one would be to provide financial and healthcare support for patients with long COVID. There's just too many patients who are suffering on their own without proper medical care or without even the acknowledgement of disease from the medical community. And that really needs to change. We need to have a lot of long COVID specialist centers that can oversee the clinical care of patients with multiple and complex chronic illnesses. And the government can certainly provide incentives and infrastructure for that. Also, guaranteeing rapid access to antivirals and prophylaxis is important. As I mentioned, the earlier you can control the virus, the less likely you're going to develop long COVID. So having, readily accessible antivirals, and even like the PEMGARDA monoclonal antibodies that are used for prophylaxis in immunodeficient people. I think, if that's accessible to the wider community, I think it'll go a long way to preventing the development of long COVID. I think establishing research funding mechanism for long COVID is very important. Historically, these post-acute infection syndromes like ME/CFS have had very little investment by the government for research. And there's, centuries of evidence that infections can lead to chronic diseases like long COVID. And this has been largely ignored until now. And I think we have an opportunity now, an obligation to study these diseases, but we need support. These studies are very expensive, and we also need to have a long-term funding mechanism for younger generations of scientists to want to get into this field and to sort of have a long-term commitment to this research, because short-term funding, it might just allow us to discover a few things, but it won't allow us to be prepared for the next pandemic. And how do we prevent these post-acute infection syndromes altogether? That requires a sort of long-term and a strategic funding stream. I would also say that making the buildings healthier is a real key thing that the government can help to prevent infection associated chronic conditions. And so, especially in public settings like school or hospitals or nursing homes, right? We need clean indoor air. And we can't just ask everyone to mask all the time. I mean, these people are living there. There are some procedures that won't allow you to mask. So I think having some sort of public health standard and enforcing those standards in these buildings will go a long way of preventing transmission and increasing the health altogether. And finally, I would say that the coordinated, whole of government response is needed. We can't just have research. We can't have just patient care. We can't just have building codes. We need to have health, the labor, education, housing, disability, all these sort of programs to work together to prevent new infections and prevent post-acute infection syndromes. And so, I think the government can do a lot. I know that we are constrained right now with very limited funding for science in general, but in the future, I would love to see this long-term strategic investment in this research field.
Thank you so much. I know that we have a hard cutoff in 4 minutes, so I just wanted to give you the opportunity. If there's anything else that you'd like to share that we didn't cover in the questions, please feel free to do so.
I'm happy to also take any questions that people might have.
Can we take the question about how do the vaccines reduce the risk of long COVID?
Oh, sure. So there, as I mentioned, the quicker you can control the virus and to suppress the level of replication, the less likely that one would develop long COVID, right? So vaccines will elevate your IgG, your antibodies and T cell responses against the virus, and that allows the host to control the virus much quicker. And that's probably the reason why the vaccines reduce long COVID risk. But it's not perfect. The estimate between 20 to 40% reduction in risk, but that's definitely better than not having any vaccine. So that's thought to be the mechanism.
Just looking quickly to grab any other questions from the chat. There was one for long COVID patients who have a negative autoantibody panel, but high antibodies to spike. What could be driving that? And are there any tests or meds that should be considered?
That's a very critical question. We need to understand, as I mentioned, that what is driving the disease in each person. And high levels of spike antibody suggest that that person might have persistent virus. The high levels of antibody doesn't necessarily mean those antibodies are good antibodies, right? It just means that you're responding to the spike protein. And so that could suggest persistent virus, and the autoantibody panel being negative doesn't necessarily mean that you have no autoantibody, because those clinical panels are fairly limited in what they're looking at. They're just looking at the sort of existing well-known autoantigens. But when we do a wide human proteome screening of autoantibodies, we see hundreds, thousands of autoreactivity in patients. So obviously clinical tests will not be able to tell, but I think we need to really develop a better strategy for diagnosing patients who have persistent virus versus autoantibody versus chronic inflammation, because the current existing clinical panels are not sufficient to pick these up.
Thank you so much. I really appreciate you being here with us. I want to make sure that we get you out of here on time, but we are so grateful to have you join us. And I think everyone here who has been impacted by COVID or long COVID is in a debt to your research. So thank you for doing it, and thank you for continuing to share those things with us. We really appreciate it.
Thank you so much, everyone. I really appreciate your invitation and all the love. Thank you.
Thank you, Dr.
All right.
Iwasaki.
Thank you. Take care.
All right. Thank you so much, everyone, for being here. We're going to take a break until 6:40. And so that is, let's see, 25 minutes. So if you need to run and grab a snack or anything, I know I always say that, and it probably sounds like I'm always thinking about snacks, and the reality is I am. So I'm going to go run and grab a snack, and I will see you all back here in 25 minutes.
I just want to add something to everyone who participated here and putting your question in the chat. I want to remind you that hold on to your questions in the future when we promote the next forum, which is coming up in March 4th. Will be our next forum. You can send these questions, and so we can include them for our speakers. Because we're always looking for, what people want to find out. And also we're all volunteers here. We can use your help in creating the list of questions. So if you actually can have questions and you put it in the chat, but maybe you can just post it as a response to when we announce the next forum, so that we can include all the questions, so we can work on it with the speakers. Thank you.
All right. Welcome back, everyone. Thank you all for being here at our Mask Together America Long COVID Defense Series 2 forum. Our next speaker is Betsy Ladyzhets, co-founder and managing editor of The Sick Times, a nonprofit news site covering long COVID and the ongoing pandemic. As a journalist, she's focused on COVID-19, long COVID, and the future of public health. Prior to The Sick Times, she ran the COVID-19 Data Dispatch, a newsletter and blog that provided news, resources, and original reporting on COVID-19 data, and outlasted the CDC's own COVID-19 data newsletter. She was a journalism fellow at Muckrock, where she contributed to award-winning and impactful COVID-19 investigations, such as the Uncounted Project, investigations into the National Institutes of Health's Recovery Program, and stories covering public health responses in several states. She is based in New York City. So thank you, Betsy, for being here with us today.
Yeah, thank you for having me. And I know Miles, the other co-founder of the Sick Times, is speaking as well. So we're both glad to be here.
And we're glad to have both of you. Thank you so much for being here. So our first question tonight is, what is long COVID to you?
Yeah, so for me as a journalist, I really see it as the greatest public health crisis kind of ongoing from the pandemic that we know is also continuing with new infections every day. Um, I see it as absolutely vital story that touches every aspect of science, health, as well as culture, policy, so many other kind of disciplines. Something that there's always endless issues and topics to cover. Also, of course, long COVID itself, I see as a complex chronic disease that can be really life-changing for people, that can lead people to lose their jobs, lose their homes, in some cases, have their worlds and their sort of frames of life be confined to their beds, um, and really can have really a very profound impact on people and on families and on communities. Um, Although that said, I think one thing that we always try to emphasize at the Sick Times is that long COVID, while it is massive and is a huge kind of unprecedented crisis, it's also not new, and it's not mysterious. Not only is there new research coming out every day, there's also a long history of other infection-associated chronic conditions. So that's kind of a balance that we try to strike in both covering sharing the urgency of long COVID, but also trying to bring in context and background. Um, yeah.
Thank you. Based on reports on long COVID by patients, what strategies are essential in preventing long COVID?
Yeah, so I think both Sinéad and Dr. Iwasaki kind of talked about this earlier. But really the best way to prevent long COVID is reducing your risk of SARS-CoV-2 infection. So that of course means high quality masks, N95s, KN95s, or like even the P100, P99 masks if you have access to those. Improving air quality, testing, staying home if you're symptomatic, avoiding gatherings, all of that stuff, I think obviously continues to apply. And I think also folks were talking earlier about the importance of rest. If you do get a SARS-CoV-2 infection, not pushing yourself, like really letting your body, heal, letting your immune system do its work. As well as like antivirals. We have some research showing that Paxlovid, as well as metformin, which is commonly known as a diabetes drug, but also has some antiviral properties, can help reduce risk of long COVID if taken during the sort of acute COVID period. And we actually have an article on metformin in particular at the Sick Times that I think is a really nice resource if you're less familiar with that one, and is good to maybe bookmark and like send to your doctor or something if you end up needing it. It's unfortunately kind of a lesser known drug, but there is a bit of evidence, like quite a bit of evidence at this point showing that it can potentially be helpful. Yeah.
My goofy moment of getting diagnosed with prediabetes was being excited to get metformin access. So I was very excited to hear about that connection. I think that's a really great thing that lots of people need to know about.
Yeah.
Why do we need a news outlet that focuses on long COVID? What motivated you and Miles to create the Sick Times?
Yeah, so prior to starting the Sick Times, Miles and I both were freelancers, independent journalists who were writing about COVID-19 and long COVID for various different publications. And we sort of met and became friends as we were commiserating about how frustrating that process could be. Often editors or other journalists at more mainstream publications or even like specialty publications focused on science and health topics did not really have great knowledge of long COVID or would not really be interested in the stories that we knew that like community members and readers would be interested in. So often, I had this experience a few times of pitching what I thought would be like a really big comprehensive feature and then having it sort of pared down to a short news story. I think Miles, as well as other journalists we know with long COVID, have talked about being asked to write an essay or something like that that is more positive and sort of downplays the seriousness or the urgency of long COVID. And so we really wanted to have a space for news articles that like didn't do that, that treated this topic with the urgency and the expansiveness that it deserves, as well as being a site that was really community focused. The estimates are the estimate is that 400 million people globally have had long COVID or have experienced long COVID, and that includes millions in the United States, millions in many millions in other countries. And that is, bigger than like that's a massive audience, right? If that were like a city, it would have several competing newspapers. And so we really thought there was a need to deliver news and commentary and other kinds of media specifically for that audience. And so that is that's one of the core missions of the Sick Times is to deliver news that is specifically for people who have long COVID, for people who have other infection-associated chronic conditions, and other related chronic illnesses, as well as their loved ones, their community members, and other allies like all of you.
Why is telehealth vital for people with long COVID? How are restrictions and even elimination of telehealth services for many patients affecting people with long COVID?
Yeah, so I think this question was maybe based on an op-ed we published a few weeks ago by a writer and advocate named Ali Lob. I'm actually not sure. I've never said their name out loud before, so hopefully I got that right. But they wrote about the importance of telehealth for long COVID and specifically talked about their own experience and their partner's experience. Both have some form of long COVID. And so they talk about the importance of remote appointments for people who don't necessarily have the capacity to go to the doctor in person, or for whom maybe a doctor's visit might be the one outing that they're able to have from their home in a given week or a given month or even longer than that. For people who are on the more severe end of long COVID, any kind of small action, going down to even something like a single conversation with somebody or eating a single meal, something like that, can lead to post-exertional malaise. And so, being able to kind of reduce energy expenditures as much as possible can be really crucial. And so telehealth obviously helps a lot with that. And then, of course, also it reduces the risk of new infections, especially times like these. I live in New York City where we're having just like record flu cases, in addition to COVID, of course, and other airborne pathogens. So I know I'm not, I don't want to go to a doctor's office right now. I don't want to go to an urgent care right now. And so that is another way that telehealth can really serve people, is kind of still getting some medical care while reducing that risk. And of course, also a lot of people live in more remote areas where it's the medical care options are fewer and further between. And so telehealth can help with that and many other points as well. I think the op-ed really goes into, more than I can say right now because I wasn't the writer.
What kinds of stories about long COVID get people interested to learn more about it?
Yeah, this is kind of a tough question for me to answer actually, because as I was saying earlier, we really consider our audience to be like long COVID community members. So generally people who are already interested. We're not necessarily writing for or like editing for that more like less aware audience, although certainly we know that readers will share our stories and we do see kind of what gets picked up the most. So I think, personal essays and op-eds, like Ali's that I was just talking about, often really resonate, as well as stories that kind of speak to like common experiences. I think one of our most popular pieces was a story we published early last year about friendship in the ongoing pandemic and discussed the experiences of people, both people with long COVID and also people who continue to mask and continue to take other acute COVID precautions for whatever reason. And how for many folks, they've lost friends over that, or they no longer have like social experiences or social lives in the same way that they did before 2020, or they found new ways of approaching all of this stuff. Um, And so I think that story got shared around a lot just because it's obviously such a common experience and people really appreciated seeing that reflected. And we also do, we cover scientific research, we cover health issues, we cover government policy. Um, and I found that some of the political stories and some of the research stories also can have kind of a wider reach. We've had the opportunity to collaborate with other publications a couple of times. Like I have reported a lot on the National Institutes of Health's Recover program, and a couple of those stories, both before the sick time started as well as at the sick times, have been with Stat News, which is a pretty major like science and health medical journalism outlet. Um, so I think the fact that they would be interested in sort of republishing those stories, I think speaks to the utility and sort of the reach of covering that specific topic, just because Recover is a huge program. It's like $1.6 billion at this point. And so that sort of is a government that becomes sort of a government accountability story in terms of how the NIH is using or not using wisely, perhaps, as some advocates would say, that funding. So that story, I think, interests a lot of people, even if they're not necessarily closely following the long COVID research itself.
How are some long COVID patients turning to AI for assistance? What are the pros and cons of doing that?
Yeah, so this is also a topic that we published a story on recently. This was a news feature by a writer, Mohana Ravindranath. Hopefully, I'm saying her name right. Who is an experienced health tech journalist. And so this story talks about how people with long COVID, some people are with long COVID are using chatbots for help with following research and managing symptoms. So that includes, the kind of big ones that everyone's heard of, like ChatGPT, but there are also a couple of tools, sort of an emerging area of chatbots or AI tools specifically designed for long COVID and for infection-associated chronic conditions. There's one by a telehealth company called Rhythm or RTHM, if you see them online. There's another one by a different company called Turn2, which is out of Australia. And so both of these are AI platforms that are specifically trained on long COVID research and are meant to help give people information. I think the way that it works is folks can offer information about their symptoms. I believe like put in medical records, things of that nature, and have the tool maybe recommend like drugs that you might try or things that you might ask your healthcare provider about, stuff like that. So obviously there are a lot of drawbacks to this. People have very complicated feelings about AI. I think when we posted this story on social media, there was a huge kind of debate in the comments, which, is I think unsurprising given this topic. So obviously there are concerns about AI tools giving incorrect information, hallucinating. There are also concerns about people's privacy. Is your information like if you're putting your medical records into a tool, how is that going to be used later? As well as obviously environmental concerns about like furthering disparities in places where there are, data centers that are being used to maintain these tools, things of that nature. So it's a really complicated topic. I mean, certainly as journalists, we're not using AI very much. We're not writing anything with AI. We're not generating content with it. We are really adamant about not using it for that purpose, but certainly there is some utility for the tools. Of course, like AI is baked into every search engine now and other things like that. So I think it's a topic that will continue to cover, as this field continues to grow. And of course, a lot of research and a lot of healthcare settings and organizations use AI in different ways too. So it's yeah, I think it's going to continue to be something we write about.
Why do you think some healthcare workers oppose masking? Are they oblivious to the lethal and chronic impact of respiratory infection and transmission of dangerous viruses such as SARS-CoV-2?
Yeah, I mean, obviously, not a question that can be answered universally, I think. Probably some people are oblivious. I think we all know from personal experience that healthcare providers often are very busy. They're often doing a lot, seeing a lot of patients, and don't necessarily have the capacity or the time to keep up with every like research trend. Indeed, there are statistics about how it takes over a decade for new research to go from the sort of scientific paper realm into clinical practice. And so I think that also applies to things like information about airborne viruses and the dangers of SARS-CoV-2 and all of that. Um, and then in addition, I think, a lot of healthcare providers who I've interviewed in the last few years feel a lot of trauma from that intense time in 2020 and 2021, especially in places like New York City that were really hard hit in those early waves of the pandemic, where, ERs were full and there were ambulances all the time and just it was I think that was a very traumatic time for people, and some healthcare workers just feel resistance to going like returning to that in any way. Even though those of us who follow the science and follow the data know that, of course, COVID is still here. Cases are increasing again across the country right now. So yeah, I think it's challenging, and of course, whenever I'm talking to healthcare workers or even talking to other science and health journalists, and I hear phrases like during the pandemic in the past tense, I always try to correct them and try to like remind them that we know during the pandemic, in fact, is today still. But that I think is kind of a yeah, it's an ongoing communications challenge for sure. Um, and something what really just demonstrates both why medical education is needed about COVID, but also this kind of broader systemic challenge of, how do we make it easier for healthcare workers to learn new things and keep up with the science along with everything else that they're doing.
Primary physicians don't diagnose patients with long COVID. Should they get trained to share the burden of the overbooked long COVID specialists?
Yes. Yeah, I think that is definitely an area of interest for a lot of specialty long COVID clinicians and researchers. One thing I wanted to shout out is that there are a couple organizations that have put out guidelines for physicians on long COVID. One is from the Cohen Center or CORE at Mount Sinai, and then there's also one from the Bateman Horn Center, which special is like a long-term time ME/CFS research, now long COVID research in the last few years. So both of those, I think, are organizations that are putting out resources and are trying to address this need for more education for all different types of physicians, but especially primary care physicians. And there are also some other kind of education focused programs, some of which we've reported on. For example, the Federal Health Department has funded about a dozen long COVID clinics through the Association for Healthcare Research and Quality, or AHRQ, through a grant program that aims to both support multidisciplinary long COVID care, as well as supporting education. So all the clinics that got these grants are supposed to be educating other clinicians, primary care physicians, and others in their regions, and doing things like telehealth consultations for patients who maybe don't live close enough to the center to come to that center, but could get some advice or care kind of remotely. So that's something that I think definitely is worth looking into if you're not familiar, or if one of those clinics is in your area, is kind of worth checking out. We've covered them a little bit, and there's also we can put some links in the chat. I'm trying to answer. I know there's a lot of questions, so I'm trying to answer relatively quickly, but I think Miles and I will try to put stuff in later as best we can.
Yeah, Miles has been pretty active in chat there, sharing some of the articles. So if anyone heard an article mentioned in the last couple of minutes that you thought sounded interesting, Miles has been putting a lot of the links to those articles in the chat as well. Some medical professionals blame anxiety as the root cause of chronic symptoms after acute COVID. Some even send patients to see a psychiatrist. How can people push back against this misconception?
Yeah, so I wanted to start by just saying, like, this is definitely a misconception. We have so much research at this point, identifying potential biological causes of long COVID. I think Dr. Iwasaki kind of went over some of them earlier in terms of viral persistence, immune dysregulation, gut microbiome issues, vascular dysfunction, like all of this stuff that is really, really well documented that we know is contributing to symptoms. So I think, if that's something that you're dealing with, sharing resources is helpful, like those I mentioned earlier from Mount Sinai's core, from the Bateman Horne Center, or from other expert clinicians that have experience in long COVID and related complex chronic diseases. There are also guidelines out there at this point that don't recommend that don't recommend psychiatry necessarily, or don't recommend the protocols called graded exercise therapy and cognitive behavioral therapy that have like a long history of harm for the ME/CFS community specifically. So guidelines like the National Academies of Science, Engineering, and Medicine, or NASEM, which put out a long COVID definition report a couple of years ago. That's a really good resource that goes into a lot of the research, and they also have, in addition to like a really comprehensive report, there are also short versions of it that can easily be shared with like a medical provider. There are other guidelines. I think NICE is in the UK is one there. And there are also advocacy groups and sort of education focused groups like Long COVID Physio, which is one focused or like a group led by expertise of people with like physical therapy experience, that specifically talks a lot about why exercise is not recommended as a long COVID treatment. Um, so I just kind of shouted out a few, but I think there's a lot out there that you can kind of share with a medical provider to explain why long COVID is not quote unquote in your head. Um, and we have a lot of articles at the Sick Times that speak to this too, of course.
What can the public do to prevent long COVID?
Yeah, I think what I said earlier, encouraging masking, clean air, testing, um, more access to antivirals like Paxlovid, other drugs that we know can be helpful like metformin, um, plus vaccines. I think, Dr. Iwasaki was talking about this a lot earlier. Um, so I think Yeah, I think there's a lot of evidence suggesting that getting a updated COVID vaccine every year or more often, if it's available to you more often, can be helpful in at least reducing the severity of potential symptoms if you get infected. And that applies, I think, also to other viruses. I think the current political climate and current health administration, the current health leadership in the US really has led to a lot of great science communication on how important routine vaccinations are right now, like flu shots. Seem a lot of encouragement for that, so um, yeah.
What are the pros and cons of longitudinal long COVID studies based on surveys?
Yeah, so I guess, there are different types of long COVID research. This is maybe one of them. Perhaps less common. I think this was really common, like starting in 2020 and 2021 when long COVID clinics were starting to get set up. Unfortunately, these days there are fewer of those, which I think is another question later. Hmm. Certainly following people with long COVID over time is really helpful for collecting data understanding longer term trends. I think some of the most valuable projects like this have included tracking people's symptoms through surveys as well as biological testing. I think one project that we have cited in stories and stuff like that is the link at UCSF. See if I can remember what it stands for. It's like long-term infection of the novel coronavirus, something like that. But it's LINC if you want to look them up if you're unfamiliar. And this was a project that was started pretty like early on in spring of 2020 and has continued to regularly follow people and do different testing, things like that. And so that project, I think, has contributed to a lot of different research studies and led to a lot of useful data that scientists are still analyzing, as well as the NIH Recover program, has a big component of that is also observational research like this. Yeah, I think some of the challenge with this kind of study sometimes can come with who is included or who is represented. Because if a study is based on a particular clinic in a particular city, it might not be representative of like other groups of people with long COVID. Also, I think a lot of these studies, at least from what I have seen, tend to focus on people who are hospitalized for acute COVID or people who were seeking a particular type of medical care. And obviously, we know that a lot of long COVID is not captured in that type of data. A lot of people are not necessarily connecting their symptoms to a COVID case. I think, as folks were talking about earlier, so it can be challenging to kind of make those connections. Um, yeah.
We are just about out of time. So before we tag Miles in, I wanted to just see if there's anything that you wanted to share that we didn't ask about during this session.
Um, yeah, I think I would just say, the Sick Times really is trying to serve people with long COVID, the greater community. So we're always interested in tips, pitches, questions. You can email us anytime. You can reach out to us on social media. Follow our newsletter, follow whatever your social platform of choice is. And we always want to hear from you. We're a small team, so sometimes if someone has an idea, we can't like jump on it right away, but we really do our best. And we always keep track of things for later if we can't like immediately do some reporting. So, yeah.
Sweet. Well, on behalf of everyone here, thank you so very much for being with us, and just love that this is work that you guys chose to do, and really appreciate having, really great journalists taking this on and making sure that we're staying informed. So you're the
Thank you.
best. Thanks for being here.
Thanks
And
for having us.
Miles, your co-host, co-creator, is up next. So we'll just give a little intro to Miles, and then we'll pivot over to talking to him a little bit. Miles Griffis is a co-founder and the executive editor of The Sick Times, a nonprofit news site covering long COVID and the ongoing pandemic. He developed long COVID at the beginning of the COVID-19 pandemic and has used his lived experience to report on the disease for a variety of publications. As a freelance journalist, he's also written about health, climate, and queer issues for National Geographic, Popular Science, Vox, and many others. His essay, How to Live and Die with Long COVID, was recognized as a notable selection in the Best American Science and Nature Writing of 2025. He's based in Southern California. So, Miles, welcome. Thank you for being here. So glad to have you.
Thanks so much for having me. It's great to meet you.
Yeah, wonderful to meet you too. So our first question for you is, what is long COVID to you and how does it impact your life?
Yeah, yeah, it's a big question. Long COVID has impacted my life for almost 6 years now. I got sick in early February of 2020. and lost my taste and smell. And in the coming weeks, developed what we know as long COVID now. My symptoms present really neurologically. I also experience a lot of fatigue. Um, I've been diagnosed with, comorbidities or co co-related diseases like dysautonomia. Still looking into other things as well. But yeah, it's profoundly impacted and changed my life. I live with what we would consider to be a mild case of long COVID, and that is just such wild language for the severity of long COVID is massive. Like we know people who have extremely severe long COVID who are bedbound. Um, so I always try to platform sort of that experience of long COVID. But it's also complicated to show people what a mild case of long COVID looks like. I might look really productive from, what I do at the sick times, but a lot of my time is spent resting or recovering or not doing much after, like after a work day. So yeah, I mean, it's a very profound and impacting illness, and it amazes me that, it affects tens of millions of people, or sorry, hundreds of millions of people around the world, and so few people acknowledge it or understand how it impacts people's lives.
Why is it essential for long COVID to be publicized but not politicized?
Yeah, I mean, I think what we really focus on with the Sick Times is telling people's stories and telling stories about long COVID. I think there are so many stats and studies, and it's hard to, I think sometimes it's hard to understand these massive numbers of 400 million. Um, and so I think telling people's stories and bringing a human element to what it's like to live with long COVID is super important in spreading awareness about the disease, what it's like to live with, and kind of reminding people um, that it is ongoing. I think there's a huge sort of we see this in a lot of media that is still happening today, where it's people with long COVID are sort of presented as, the people that got sick uh, during the pandemic, and how sad for them. Um, and, we need to help them, but there's not really much acknowledgement of actually how to help people, which is through research, through support, through policy. And there's also so little acknowledgement of that people are still developing long COVID. We see studies that the more times you get long COVID, the more likely you may be to, or sorry, the more times you have COVID-19, the more likely you are to get long COVID. So presenting it as ongoing and showing people that they are still at risk is super important.
Some doctors are unwilling to attribute their patient's symptoms to an earlier infection of SARS-CoV-2. If someone suspects they have long COVID, how can they advocate for themselves?
Yeah, so we've put together some resources. It's kind of hard because you might have a doctor who might be more open-minded, and they might sort of at least understand and have heard of long COVID. Of course, that's not the case, unfortunately, for everyone, and for the majority of people. So we found it helpful. We put together some resources about how to talk to your healthcare provider about long COVID. When we did a group of resources called Long COVID Essentials. And that's just sort of a way to bring up, if you think you have long COVID, there are some co-diagnoses that can be useful in treating. There are some, there are some treatments that help some people. They don't help everyone. But if you are a candidate for them and they might help you, they're worth asking your doctor about. So we put together this resource of just sort of how to bring research to a provider. Those care those I put some in the chat earlier, but like the Bateman Horn Center has a clinical guidance. Mount Sinai's core has clinical guidance on IACCs. So if you can bring those to your provider and maybe help educate them, you may be able to help educate the provider and then help many other people who have IACCs.
Thank you. We were originally going to ask Betsy this question, but we ran out of time. So to throw a little bit of a curveball at you, but long COVID clinics are closing across the country. How is that affecting patients with long COVID and those seeking diagnosis?
Yeah, so we've sort of seen like the rise of long COVID clinics, I feel like was 2021, 2022. And I feel like in the last kind of year or two, we've seen a lot of clinics closing, not just in the US, but kind of around the world. So there definitely seems to be sort of a trend of this happening globally, unfortunately. Um, I think long COVID clinics have kind of a complex history. When I reported on them sort of earlier on in the pandemic in like 2021, 2022, they just sort of had mixed results. Some were helpful and some were very unhelpful, and some were potentially even harmful because they would prescribe uh, like physical therapies and exercise therapies without sort of evaluating people for post-exertional malaise or other components of long COVID. So I think there are a lot of great clinics that have that do help people and are following the emerging science. They're looking at clinical trials and they help enroll people in clinical trials. So the loss of long COVID clinics it's leaving a lot of people without like good providers who understand long COVID. A lot of these clinics also had social workers who could help um, patients navigate daily life. They also had occupational therapists who could help with a lot of like neuro symptoms and cognitive symptoms. So those were great because you could see a lot of different specialists or providers in one place that really understood long COVID. And usually they were integrated within a care system, so they could send you to a neurologist who was hopefully seeing a lot of long COVID patients or a cardiologist. And now we're sort of seeing that a lot of these people are being sort of like pushed back to their primary care providers, who may not be as informed about long COVID, or they might not be set up to have the time to see long COVID patients, because an appointment with a long COVID patient, I feel like usually takes like a good one. You need sort of an hour to go over a lot of different things. You can have, long COVID can be 200 symptoms. Um, so if a person's coming in with 20, it's very hard to kind of figure out what might be most effective for them. So it's really disappointing to see so many of these clinics close because we're not seeing in research that long COVID is like exponentially going down. People are continuing to develop it and people are continuing to get sick from COVID. COVID's not going away. So I really don't understand sort of these larger systems plans, besides sort of denial of long COVID in healthcare.
Why do some people get officially diagnosed with long COVID and some with similar symptoms can't? How are long COVID patients navigating the discriminatory, complex, endless, and expensive diagnosis process and struggling to get care?
Yep. So this is a big question, I think, that comes in, I think, just how the healthcare system is very broken, especially, I mean, I'm speaking mostly from the United States perspective. I live in California. We see really high rates just to have a good healthcare plan, even if you're on sort of a subsidized plan, whether it's Medicare or Medicaid. So it's incredibly difficult to even like afford the healthcare to see a lot of providers. Um, and with places like long COVID clinics closing, you're being sort of, you might see a PCP who sends you to multiple different specialists. Even if you have a healthcare plan, that can cost $100, $50, depending on your copay to see a specialist. So it makes those specialties difficult to see, and those might be the ones who can help with long COVID, depending on their expertise and knowledge. But they might also be unaware. I know I've seen cardiologists who had no idea what to do with anything with long COVID, and neurologists, and I felt like I was bringing them, uh, more research and had more knowledge on this disease than they did. And I think a lot of people with long COVID who, read up on the disease and study it feel when they see providers who are less informed on the disease. Um, does that answer the question? Sorry, what was the second part of it?
The second part was just how are long COVID patients navigating the discriminatory, complex, and endless and expensive diagnosis process?
Yeah, I mean, everyone is figuring it out in the best way they can, and they're not being supported in the way that they should. I think a lot of people are relying on, um, support groups have been extremely helpful for people with long COVID over the past 5 years. They can help people identify, providers who understand long COVID in their area that they could see. Um, they are, yeah, I think so. Those are some things, and then I think the other ways there are sort of these emerging clinics, like Betsy mentioned some. There are like some virtual clinics who are specializing in long COVID, like Rhythm. Um, and I know, I don't think Bateman Horn does online stuff, but there are these centers and clinics, Bateman Horn, um, you know, Mount Sinai in New York, who are really leading the way in um, like bringing more informed care to long COVID and IACCs. But of course, if you don't live near these places or you can't travel to them, they're not accessible to you. So it leaves out a lot of people with long care and with long COVID, and a lot of people with the disease aren't getting any care.
I just want to interrupt and add that I think we're very interested in more investigation in how insurance coverage for patients when they are unable to get the long COVID diagnosis. Sometimes they cannot get into medical trials. They cannot get insurance coverage for these testing because for we don't have biomarkers for long COVID yet. And a lot of these long COVID specialists or even if a primary physician is interested in diagnosing a patient with long COVID, in order to get insurance coverage, you have to have long COVID diagnosis. Does that make sense? And I
Yeah,
think
yeah.
it would be great if more journalists go after this topic and really expose the hardship of patients going through the process.
Yeah, so I see what you're saying. So a lot of it's kind of mixed, but some clinics, like early on, at least long COVID clinics, you had to have like a positive COVID-19 test on your record to be admitted to the clinic. And some studies and like clinical trials also have that um, as like a prerequisite to be included in the research. Um, so it's a really difficult, like, I think not all clinics do that, not all trials do that. So it's not, every single one, but it does make it really difficult for patients who, it's really hard to get a PCR test for COVID because they can be really expensive. You might have to be paying out of pocket. Um, and then there's a lack of tests. Like it's very hard to get rapid antigens. And sometimes they won't, different clinics and stuff won't take, um, a rapid antigen test, so you have to get a PCR. So it greatly limits who is getting care, and it's because the entire ecosystem is sort of set up in taking away long COVID and COVID-19 resources. It's something we've looked at. I've looked at this in some long COVID. My first story on um, clinics looked at like the discrimination of not having a positive test because even major definitions don't require positive tests. They are more about sort of timelines and what symptoms you have. So a lot of those recommendations should be adopted by these clinics, and some people argue in the research too because it can be hard to do that. And then some researchers will argue that they need those positive tests because it can then confirm that a participant has had COVID-19, but many of us don't have those tests, so it leaves a lot of people out, and they need to be included as well.
When patients are unable to recover from COVID months and years later, what should they do?
It's a tough question. I think I think my main thing is to hold on. There are really brilliant people who are working tirelessly to, um, find, find cures, find treatments for long COVID, understand the pathobiology so we can treat it. Um, and then there's also advocates who are working really hard to find support and get better policy for patients with long COVID. Um, so I think, there's become sort of a movement, I think, within long COVID and the COVID cautious community of mutual aid, since the government isn't taking care of, governments around the world aren't taking care of a lot of people with long COVID. We've seen communities step up to do that work. I mean, Mask Together America is doing that work by educating the public about the effectiveness of masks for respiratory illnesses. There are mask blocks who are doing similar things and distributing masks. There are clean air groups who are making spaces safer with clean air and lending libraries. So there's a lot of hope, I think, in our community and people with long COVID and related diseases, and the greater COVID cautious community who are stepping up during this widespread governmental failure. That gives me a lot of hope, and as does sort of this, advocates and researchers and people who are really working hard to make this happen and find out, how we can how we can increase the quality of lives for people with long COVID.
Are there specific concerns about whether it's safe for long COVID patients to participate in medical treatment trials?
Yeah, so every single clinical trial they'll kind of, I think, on like if you go to the clinicaltrials.gov page, um, each each trial will list sort of what intervention they're studying, what the side effects are, and there'll be criteria to take part in a study. So if you ever go through sort of the process, you'll be sort of screened by someone associated with the trial. They will always tell, like, they'll talk about the potential side effects of a drug. Um, a lot of them, are being trialed in people with long COVID for the first time. They might have been deemed safe in another disease state or condition. So there's always a risk within clinical trials that they could make symptoms worse or all these things. So it's important for people with long COVID to, I think, read, really see like what is being trialed for an intervention. I think get feedback from their doctors if they're able to before, work with your medical care provider if you have one. see what they think of a trial. Yeah, that's super important. Just sort of reviewing and then weighing the risks in clinical trials. There are, yeah, it's just important to talk about them and do sort of a benefit analysis of what makes the most sense for each person.
Can you share how patients are impacted by long-term placebo medical trials?
Yeah, so um, yeah, could you say more about that?
Maybe Julie can say more. She wrote the question.
Yeah, I can elaborate on that. So there are medical trials that are double-blinded, and
Yep,
you could be on placebo or you could be on the medication. And the
yep,
medication could be very helpful, but you could be on placebo.
right. Yes, got it. Okay, so yeah, so um, there's a couple of different types of clinical trials, so that's also important when potential participants are looking at a trial. You could have so what's called Julie's referring to as like a randomized controlled trial, and that means they'll be testing, say, an intervention with a placebo. So half the people say will get the intervention, the drug, and the other half will get like um, a fake a fake pill or something that's not the drug. Um, and you could go in that trial and you could take that for a year, for 6 months. It just sort of depends on how long. Um, so you might the medication may help people with long COVID. And so you may be left out if you don't get that. There are some trials that you can sort of read before in the trial page, but in the specifics, sometimes they will then, if the trial is effective, sometimes they will also give it to the people who had the placebo. That doesn't always happen. It just is kind of case by case. Um, there are other trials that don't have placebos. Like we wrote about one yesterday, or I wrote about one on Tuesday for that UT Health Austin is doing. And it is, there is no placebo. So everyone is getting the intervention, and it's to test sort of the safety of that drug within the community within long COVID. So if you're really if you're hoping to get the intervention, you're usually looking at like a phase 2 clinical trial. Sometimes those are ones that are usually sort of testing like um, I guess like the safety profile of a drug. But that's not always the case. But sort of looking at those trials before, if you want to get the intervention or partake in research that does, then you can do that. And then I note that it's always important. I think these big trials that have the placebo, while it's a disappointment, it may be a disappointment if people are improving on a drug and you get the placebo. You're contributing to a really important part of science by being in this placebo. And you're contributing to science that will, if that drug becomes effective, make it accessible to other people with long COVID or whatever disease it is sort of testing.
So we know that long COVID kills. How do we know how many people are dying from long COVID?
This is a super hard question. So yes, we fully know the long COVID is kills. We have reported um, on this at the Sick Times, and Betsy has done some prior work on this at Muck Rock, which is our fiscal sponsor at the Sick Times. Um, and the CDC put out a report. Betsy, was it 2023?
It was like January of 2024, I think. I'll see if
Okay.
I can find
Yeah.
our story about it, put it in the chat.
So they basically, I think it was an electronic healthcare record study, and they basically found, like, would look at people's electronic healthcare records who had passed, and if, like, uh, they could find if long COVID was listed um, as a cause of death. So they had many thousands. I think it was like over 5,000 in that study in 2024. So it's a lot of experts have uh, stated that that's likely a really large undercount. We know that COVID is being, or long COVID is being, is because a lot of people, there's the care gaps in knowledge and providers I was talking about. So a lot of people aren't being diagnosed with long COVID. They don't even have it on their healthcare records. And a lot of complications from COVID-19 and long COVID, whether it's heart issues, blood clots, other things that can be deadly, um, may be counted, but the connection to their COVID-19 infections may not be. So it's a big undercount. And there's not a ton of research that is happening around it. I know UCSF is doing some interesting studies on people who have passed of COVID-19, and they're trying to look at more pathophysiology from that and from long COVID. Um, so hopefully more research will tell us more, but we certainly need much better answers on how many people are passing because of long COVID.
Yeah, just to clarify, like that existing data are from those existing data are from death certificates. And there is huge inconsistency across the United States in how death certificates are filled out. It depends on if someone passes in a healthcare setting versus at home. And then in different states and counties, there might be someone with more medical training who investigates the cause of death versus in a lot of places it's an elected coroner who may have no training. And so my colleagues and I, when I worked at Muckrock, spent a lot of time looking into this in the context of COVID and also long COVID, and found just like a lot of issues and discrepancies. So I think, to furthers Miles' point that any numbers that we have are really significant undercounts, and that goes for both COVID deaths as well as long COVID deaths.
Yeah, I mean, if you look at the official like World Health Organization death count from COVID-19, I think it's at like 7 or 8 million. And then sort of the excess deaths that are estimated, which may be like the larger number from COVID-19. I think they're as high as like 25 to 30 million. So it just sort of shows like the official numbers are always much less than the reality.
Thank you. So we are just about out of time, so I wanted to give you the same opportunity that Betsy had. If there's anything specific that you wanted to talk about long COVID that we didn't address in the questions, this is your chance to soapbox a little bit if you'd like.
Yeah, I mean, I think we covered a lot. I would just say that we at the Sick Times are always open for like tips. So if there's, something you see going on, that you think's worth reporting on, please send us an email. We try to take on as many stories as we can. We are a small team. We're only 3 people right now. We are gaining a podcast producer soon. We're hiring for that right now. So we hope to tell more stories through audio format soon. And we're also open to pitches. So if you have, a story to tell on long COVID, or if you think there's something we should cover, you can always email us at editors@thesicktimes.org.
Perfect. Thank you so very much. All right, folks, we are just about at the end of our presentation. We have Dr. Robi Tamargo from our board here to give us our closing statement when you're ready, Dr. Robi.
Good evening, everyone. I'm Dr. Robi Tamargo. I'm a clinical psychologist in Florida, a very proud advisor to this wonderful grassroots advocacy group full of incredible volunteers working hard every day to help end this pandemic through mitigation education while supporting the community of survivors with COVID-related health issues. Thank you all for joining our forum and supporting our educational social media campaign. Every effort counts, whether you share our posts or add an emoji to a comment. Your action will really help us disseminate the information that we learn through patients and scientific researchers. As a long COVID patient myself, and now a long COVID mental health specialist, it's disheartening to hear so many people are struggling to be diagnosed while we've been waiting for FDA-approved treatments for 6 years. As COVID continues infecting more and more people, the long COVID patient population is growing. It's sad and disappointing to see people who take precautions are being marginalized, publicly humiliated as jokes, or targeted by public figures. The most devastating is how COVID response resources are being defunded and people are being restricted from accessing preventative tools and treatment. While it's challenging, long COVID advocates are really needed to encourage put our differences aside and do what's in the best interest of public health for the greater good. I think uniting makes us stronger. All of our forums are being recorded and edited. We'll share on YouTube and Facebook in full. Julie, who you've all met, is our content creator and MaskTogetherAmerica's founder. She will edit tonight's recordings and create PSAs for people to ensure that they can share the valuable information on Instagram, Facebook, X, Blue Sky, and our website, which is www.https://masktogetheraamerica.org/resources. Thanks again to our amazing speakers, and thank you all for joining us. Have a good night.
Thank you, Dr. Robi. And just a quick note for everyone that we are going to have another Long COVID Defense Forum on March 4th. So that is going to be from 5 to 9 Eastern. So watch for more information about that. I already had someone email me to sign up, which is a little premature because we don't have anything set up yet, but I love the enthusiasm. We're very excited about it. So just mark your calendars for March 4th, and that will be again 5 to 9 p.m. Eastern, and that will be on our social media, so you'll be able to sign up again through Zoom like you did for this. So once again, thank you to all of our speakers. Thank you to all of our volunteers. Please follow us on social media. As Dr. Tamargo said, we are on Facebook, X, Instagram, Blue Sky, and you can get involved with us if you have a desire to volunteer. And of course, please support our speakers and the Sick Times as well. So thank you all for being here, and have a good rest of your night.